All right. Well, good morning, everyone. I will go ahead and call the meeting to order at 10:27 a.m. on April 13th, 2026. Mr. Carlton, can we have roll call?
Yes, Dr. Zaffron,
Present.
Dr. Farmer, Mr. Kokonos. Oh, I saw him. I saw him come on.
Present.
There you are. Okay.
Present.
Mrs. Barnes,
Present.
Dr. Bhatia, Mr. Crane.
Yeah.
All right. Dr. Deloche,
Here.
Mrs. Del Rosal,
Here.
Dr. DeStefano, Dr. Green,
Present.
Mrs. Harrod,
I'm here.
okay. Dr. Jones,
Here.
Dr. Martinez, Mrs. Morgan,
Here.
Dr. Naidu,
Here, sir.
Dr. Quinones.
Present.
And Dr. Quinones is our board member present with us in the room today. Dr. Tibbles,
Here.
Mrs. Troncoso,
Present.
Dr. Vanderwide.
Here for now.
Here for now. Okay, we do have a quorum and may proceed, Dr. Zaffron.
Great. Thank you, everyone. And thank you for having this impromptu meeting. We put this out there a week ago. As many of you know, on March 27th, 2026, the Texas Medical Board adopted rules regarding the administration of parenteral ketamine, that is IV, subcutaneous, and IM for psychotropic ketamine therapy, PKT. However, the board has continued to receive comments regarding the best way to address patient safety and access to care. We sincerely appreciate all the feedback that we have received. In response, the board has decided to hold a non-regularly scheduled meeting today. This meeting will give the board the opportunity to consider whether to reopen the rulemaking process in order to take additional feedback into consideration. Board members, you will find attached a new draft rule that incorporates much of the feedback that we have received. Now, the process, the way this will work is that if a new version of the rule is approved by the board to be submitted to the Texas Register today, then it will go back out for another public comment. As always, we thank our stakeholders for their continued help in creating a rule that protects and helps our fellow Texans. The other thing that I would just kind of note on here is that, you know, the enemy of good is perfect. You know, right now we can leave things completely unattended to. And what we had addressed beforehand using OBA rules around ketamine is what will stand. I don't think that is necessary. I do think that there has got to be a happy medium of making sure that we preserve patient care and safety, while at the same time helping with access. At the end of the story, this is still a medication that is a dangerous drug. It is a Schedule III medication. It is an anesthetic medication. And we must be able to regulate how and under what circumstances it's being utilized. We heard loud and clear the concerns around having a physician present physically at all times. You know, there's a lot that will argue that that is probably still the safest way to do it. However, again, I think the proposed rules as written help to come to a happy medium where the physician doesn't necessarily have to be physically present, but has to be within a certain proximity to be able to respond to any issues or concerns. Yeah. I understand that some believe that it's easier just to call 911 and probably faster than the 30 minutes that we talked about. When we talk about a physician being available within 30 minutes, that's not to respond to somebody coding and potentially going into a cardiac arrest. It's to head up these things ahead of time before they become an even more serious issue. The ability to diagnose an issue, not necessarily just going into moderate sedation, but it could be a variety of other things. A hypertensive crisis, a hypotensive crisis, getting into a seizure, you know, whatever it might be, there still needs to be somebody there and available within a reasonable amount of time, which we defined as 30 minutes to be able to respond to these kind of things. So anyway, I think that covers the vast majority of what we try to cover in the new rule. I'm going to hand it back off to Brent, to Mr. Carlton, to kind of go over the process. We still have a rule that we passed in place a couple of weeks ago, so we would potentially need to address that first before we go on to the next step of considering some other language. So, Brent, I'll hand it back to you.
Yep. Thank you, Dr. Zafran, for kind of laying out, as part of your board member report, for item 2 of kind of setting up why we're back here again in a non-regularly scheduled meeting. But as you said, the board has continued to receive a lot of good comments from different interested parties on the rules that the board did adopt just a couple weeks ago, as you said, in March. So we wanted to, before those go into effect, we wanted the board to have another opportunity to discuss this and see if further revisions need to be made. So if the board would like to do that, then what we would need to do is under agenda item number 3, there would need to be a vote to rescind the adoption of the rules that were adopted on March 27th. And then that would kind of open the floor for the board to start discussing any, new rule language or what you want to do going forward, starting in agenda item number 4. So that's kind of where we are for agenda item number 3. GC team, is there anything else at this point other than kind of laying out if they want to kind of reopen it for additional discussion, they need to have that vote to rescind first, and then we would move on to item 4.
Yeah, not a vote, but yeah, I mean, they could definitely begin with agenda item number 3.
Yeah,
And if there's a
they need a motion. Yeah. all that,
motion
yeah.
and second, and then they could discuss further and then
Yep.
take a vote. Yes, sir.
So I will go ahead and make that motion, and I will make a motion to go ahead and rescind the rule that was passed at the last board meeting.
This is Dr.
Second.
Quinones, second that motion.
Okay, great. We have a motion by Dr. Zafran, second by Dr. Quinones to rescind the adoption of the Chapter 173 Office-Based Anesthesia Services Subchapter B concerning IV ketamine therapy standards, which would have been new sections 173.6 to 173.15, as adopted by the board on March 27th, 2026. Is there any further discussion on that motion? All in favor, please say aye.
Aye.
Any opposed? Any abstaining? All right, it's unanimous to rescind the rule as adopted on March 27th. That'll bring us to agenda item number 4 for discussion on any potential changes for a rule regarding this issue.
Yeah, so let me just highlight the very 30,000-foot level changes that we made. So the biggest change that we made is not requiring a physician to be physically present, but we did go into detail of the number of clinics that a physician can simultaneously supervise and the number of delegates that a physician can supervise. And there are some specific nuances around administering of the drug, as well as of monitoring of the drug. Let me emphasize that, again, there's 3 ways that the medication can be given. One is IV, one is by intramuscular IM, and the other one is subcutaneous. And what we've heard from a lot of testimony, especially from the psychiatrists who, to be honest with you, have been the experts in administering this drug. They're the ones who are diagnosing this condition, and they have been administering it. And we've heard quite a bit of testimony that actually the intramuscular form potentially is actually one of the more dangerous ways of administering it, because you're administering one large dose and you're going to have a peak effect, a certain amount of time later, whether it's 10 minutes later, 15 minutes later, before it slowly starts to taper down, as opposed to in the IV form where, you're starting the medication and it's continued at a steady state for 60 minutes. That is why with both IM and sub-Q, even though the drug is being administered at one time at the very beginning, that there's still that 40 minutes monitoring period. And that is specifically to allay the concerns that even though the medication is being given one time, so the administration may take a couple of minutes, but the monitoring, in fact, and making sure that that patient doesn't overstep going from anxiolysis to moderate sedation or dissociation is something that should be watched carefully, and that's why the 40 minutes are there. The other parts of of the rule that we still thought were very important to have is reporting requirements, registering of the clinic. And again, as I'd mentioned beforehand, the number of delegates that a physician can supervise at the same time and the number of clinics that they can supervise at the same time. And also holding the responsibility, whether it's a medical director or a delegating physician or the physician that is actually providing direct oversight. So I think that covers the vast majority of it. Brent, if I've missed anything else, you can weigh in there.
Sure. Did you want to talk about, any of the, potential limitations on how many patients can be administered by a physician kind of, simultaneously or during that 40-minute window versus a delegate of the physician? And then also any of the monitoring of, a physician, how many people can be monitored at simultaneously versus a delegate doing it?
Yeah. So one of the things that we did want to make sure that we have is that if there is a physician physically present there, that there is a lot more discretion given to the physician deciding what is the appropriate amount of monitoring and supervision. So therefore, the number of folks who can administer or be monitored when a physician or while a physician is physically present is different than if the physician is not physically present there. And the other thing I kind of failed to mention is that we also, for the pre-procedure evaluation and for the intra-procedure monitoring and for the post-procedure recovery, we're going by moderate sedation guidelines, the latest moderate sedation guidelines. The one I believe that is the latest so far is one that was passed, I believe it was in 2018. And that was a combination of the American Society of Anesthesiologists, the oral maxillofacial surgeons, and the American Dental Association have put forth those requirements. But since CMS in facilities, accredited facilities, mandates and requires that that the chair of anesthesia at these facilities puts forth sedation guidelines for everybody to abide by, we felt it was appropriate to use the moderate sedation guidelines that is out there to be utilized by all physicians who are prescribing and delegating this therapy as to what is the proper evaluation, the proper monitoring beforehand, and so forth. So.
Okay, great. We can open it up for board member discussion, and then we'll take an opportunity to hear from our guests that have comments today. Ms. Morgan?
Yeah, so I read through the proposed regulation, just had a few questions. I didn't see anything on clinic ownership. Do we want to include something to that it, must be a physician owner, anything about clinic ownership?
Brent, did you want to address that? My understanding is we already have rules in place as far as ownership, but do you want to address that specifically?
Yeah, in this rule, we were talking about more if the physician owner and medical director as far as the delegating and a physician there. GC, you guys want to weigh in any on what we have as far as any limitations that exist on owning a practice? Yeah.
As I understand, there's nothing in the rule that limits ownership, but the delegation rules obviously apply. And when you do register, there will be questions about who the owner and who the medical director is and who's delegating, et cetera. So more so just notifying us of who all is involved at the clinic, but no limitation as to ownership necessarily.
Board members have any other questions?
But there has to be a designated medical director. I believe Caesar's also got his hand raised, Brent.
Yep, I see that. Caesar, did you have a comment?
I'm Dr. Naidu.
Okay, Dr. Green?
This this kind of clinic would be considered a medical practice. So would it have to, it must be owned by a physician?
Again.
The rules surrounding medical practice and ownership are handled under the Texas Business Organization Code, and there are percentage requirements as far as ownership. I mean, there's obviously the corporate practice of medicine that Texas has, and physicians, or I'm sorry, non-physicians cannot practice medicine without delegation in this scenario. So they would have to follow the business organization codes for organizing their entity, for setting it up. But typically what we see in these organizations is there's at least a majority ownership of a physician, with maybe a minority ownership by an APRN or a PA or some other sort of licensed healthcare person. And typically, whenever they have physicians that are doing delegating or acting as medical director, those folks are, the way I've seen it structured is they're independent contractors. But yeah, they'll still have to follow Texas law with regard to setting up entities. And for a healthcare practice, there are rules in the Business Organizations Code that says if you're going to provide a particular healthcare service, you can only form certain kinds of entities, but also who may own those entities. Anything else to add? Okay. I hope that answers your question, Ms. Morgan.
Dr. Green.
And Dr. Green.
All right, I think Dr. Naidu was next, and then we'll go to Dr. Tibbles.
I think we're opening loopholes. Why can't we put it like a pain clinic? It's used for the pain, it's used for the opioid, it's a wild west, used for many things. You know, it's used for the alcoholism, and it's used for the opioids, it's used for anxiety, agitation, you just name it. The indications, off-label indications are so many. Then here we are sitting and trying to open up the clinics everywhere. I think it's like opening a Pandora's box for many things. I mean, I have a concern. I think it started widely used in 2018, probably came before that with some restrictions of anesthesiology. What do you all think? Are we really opening the box?
Yeah, in what we have in these set of rules is, I mean, again, this is specific to the treatment of certain conditions such as PTSD, treatment-resistant depression. You're talking about potential pain and other things that the patient may also have as well. But specifically for this rule for PKT, it is just for the treatment of those conditions as defined in the rule. We do say here in the rule also that if someone is getting the treatment simultaneously for the treatment of pain or something, then it would fall to the OBA rules, the chronic pain rules. It would go to whatever the higher level of the requirement would be if they're being treated for multiple things at the same time. Dr. Tibbles.
Yeah, I'm gonna try to unpack this in a logical way and not conflate a few things. So I think one of the challenges that I have is tying this explicitly in the rule to moderate sedation and the ASA guidelines for moderate sedation. Let me tell you what I mean. Here's what I don't mean. I like most of what's in the rule in terms of what's there for safety. But like, and I don't know if this is what you're referring to or not, Sharif, but there were 2018 consensus guidelines that ASA was involved in at the committee level, ASRA, American Academy of Pain Medicine, that published consensus guidelines that made it really, really clear distinction between PKT and moderate sedation doses. So again, I like most of the stuff that's in here, but I don't know if there's precedent for tying it to society guidelines like that. And I think it creates a little bit of confusion for me. I don't do this, but if I did, I would, here's what I'd be asking myself. Well, am I tied to what's in the rule, or am I tied to the evolving ASA guidelines? And there, things like what's not in the rule, like doesn't require anyone to be NPO, but moderate sedation guidelines do. There are evaluation things in the ASA guidelines. And then I also don't love that, that we seem to be not drawing the distinction that's, I think, really clear in the literature and in the safety evidence around PKT and moderate sedation ketamine. So I think we can accomplish both things, like get the stuff that's in the rule for the most part. But I think my suggestion might be to decouple it from kind of, again, sort of changing and evolving moderate sedation guidelines. There may be something I'm missing or some thinking or logic that I'm not, that's not obvious to me, but I would love to just chat through that.
Yeah, Jason, I can help answer that. When you're giving anxiolysis, you have to be able to rescue from the level higher than that, which is moderate sedation. So, you are giving anxiolysis. That is clearly what PKT is. You're not supposed to reach the level of dissociation, but you can. And so, if you're giving anxiolysis, you have to be able to rescue from moderate sedation, which means that you have to be able to understand what is moderate sedation, what does it look like, how to evaluate for it, how to recognize it, and how to rescue from it. Somebody who's giving moderate sedation has to be able to rescue from deep sedation, and vice versa. That's typically the way we address these, is that you have to be able to rescue from one level higher than what you're actually administering. And the criteria of making sure that a patient's properly evaluated, risk factors they're associated with, like, for example, their airway, what kind of Mallampati that they have, what kind of other comorbid conditions they have, and also what other medications they're taking. What we've seen, and I've heard this actually more from psychiatrists than from anybody else, is the bad outcomes that we hear out there are because of folks who have gone into moderate sedation and it's been unrecognized. And that's where the sentinel events have happened. So a lot of our focus is, yes, it's anxiolysis, but there's got to be a clear ability to be able to rescue from moderate sedation, especially in a circumstance where you can't reverse the drug. That's what actually makes it even more serious than, say, giving an opioid or giving a benzodiazepine.
Sharif, let's use this question that I have. It may not be the best example, but so I agree with what I totally understand and agree with wanting to ensure that the site and the staff has the ability to rescue from one level higher. I suspect if someone's doing this, they're trying to reconcile what's in the rule with also saying you are to follow ASA moderate sedation guidelines. Like use my example. The way the rule is written, I would interpret it as, now I've got to follow moderate sedation ASA guidelines for every patient, which by definition means everyone has to be NPO. But I'm not sure we would all agree that like being ready to rescue from moderate sedation is the same as having the same requirements for PKT. So I think the NPO question is a simple one to talk through.
I think it's very clear that in the moderate sedation guidelines, you're supposed to be NPO for moderate sedation. So that there's no ambiguity about that. Right. There's a lot of stuff in there that talks about what type of, again, preoperative management and questions and advice one should be eliciting from the patient. But as far as what you're going to be holding yourself accountable for, moderate sedation versus anxiolysis, that's very clear in there. If you actually read the entire document, it goes through the fact that one could go from one stage to the next, and if you go to the next stage, this is what you do, versus if you are on purpose doing moderate sedation or deep sedation, whatever it is, here are the things that you have to abide by.
So the rule as written, what I interpret, what I need all of, by the way, I'm using myself again, I don't do this work. Okay. What I need to require every patient undergoing PKT to be NPO, because I read the rule as requiring that.
The moderate sedation means that if you're going moderate sedation, you have to be NPO. If you're not undergoing moderate sedation, then you shouldn't have to be undergoing NPO status. It's very specific about if you are at the level of moderate sedation.
Okay, and I would love for someone else to read the rule and tell me if you're interpreting it how I would, which is basically the rule seems to read like you're required to follow guidelines for moderate sedation in PKT patients. And that's what I'm just trying to draw that distinction. Because I read it as I'm to follow moderate sedation guidelines for moderate sedation, which would require NPO. So that, I think you're clarifying it, but I'm not sure it's clear in the rule. And maybe I'm wrong.
Jason, you can always suggest language that makes it clear for you. I mean, that's the only thing I can suggest to you right now.
Okay, so I appreciate that, but I'm trying to just have the discussion. So hopefully there are some other smart minds in the meeting that would have points of view too. Or tell me, I'm open to thinking stupid if someone tells me like, no, Jason, that's not how the rule reads. Or if someone says, yeah, we actually want all of these PKT patients to be treated as if they're undergoing moderate sedation. And if that's the intent, we should just say that.
Any other board members have comments on this and on interpretation of as it reads currently?
Brent,
Yes,
hi,
Yeah, go ahead.
me or Dr. Naidu?
You,
And I
ma'am.
just got a one point.
Okay.
Moderate sedation, does it include the drugs like GLP-1 agonists and SGLT2 inhibitors or things like that along with NPO? Because it's an anesthetic drug. So it should apply the same thing to prevent aspiration and other things, wouldn't it?
All right, let me just give a clear point. Let me not be about my point of view. The occurrence of serious adverse events, specifically respiratory complications, and appropriately administered PKT is very, very close to zero. The idea, in my opinion, of requiring NPO plus things like Dr. Naidu just suggested for every PKT patient for the, I would say, estimated in 1 in, I don't know, 10,000 or probably less occurrences. I'm actually not sure how much documented respiratory compromise evidence is out there for PKT. I couldn't find it. Seems to be overdoing it.
Ms. Del Rosal and then Dr. Jones.
By the way, just to be clear, I do agree with the staff training and equipment and everything else in the system should be prepared for every complication of moderate sedation and beyond. So just to be, I'm also being clear about that.
I had more of a question to Dr. Tibble's point, just of the other physicians in the board. Do they read the rule the same way as Dr. Tibble's? Or, I mean, I'm just curious as somebody who's a public member who doesn't have the understanding as deep as the physicians in the board. Does anybody else read it the same way as Dr. Tibble's?
This is Dr. Vanderwide. I read it the same way Jason does. I mean, it states very clear in section 173.10 physician requirements, both in letter C and D, that the physician ordering and the physician responsible will, quote, meet the American Society of Anesthesiologists moderate sedation guidelines. It says it twice.
Is there some way, between you and Dr. Tibbles, Dr. Vanderwide, something that we could add in there as some language you could propose it as an exception that basically said, hey, you know, this is considered whatever it is, subdissociative, whatever you want to call it, that the PKT actually does, but the administering person shall be prepared for, just to kind of clarify it so that there's no question.
Maybe I'd love to hear others' thoughts, but I also, I think that things are in the rule that we want done around monitoring, including like having CO2 monitoring on site and all of this. Like, I feel like the stuff's in the rule. Maybe there's another reason to layer on the ASA moderate sedation language, or maybe it's remove it. But Zach is smart and an anesthesiologist, so maybe he has the answer.
Dr. Jones.
Oh, I'll take that as my cue. Thank you, Dr. Schultz. I want to first just specifically address the NPO question because I've got the guidelines open myself, and so I wanted to. So what I'm reading here is it says on the day of the procedure, assess the time and nature of last, and most importantly, evaluate the risk of pulmonary aspiration of gastric contents when determining the target level of sedation. and whether the procedure should be delayed. So, these guidelines, in my opinion, don't give a hard and fast rule regarding NPO status for PKT, because I don't think we need one. I like the idea that there is some deference to the physician. And we do have evolving situations like Dr. Naidu mentioned with GLP-1 medications that can delay gastric emptying, and so you do need to look at these things on an individual basis, especially when we're talking about an intended dose that is less than moderate sedation. And as Dr. Zafran mentioned, we do want to be prepared for that next level. But my reading of that is that if you're intending to give a ketamine dose that does not reach moderate sedation, then you would go by the appropriate, NPO status that the physician is comfortable with in that scenario. I didn't see any absolutes, and again, I may have missed that, and if I do, I apologize. But that's, I think, leaving it up to the individual physician and that individual patient is important. And I do appreciate that the guidelines, the 2018 that we're looking at, they do have some components that are additional to what we have in these rules we're looking at. But I like the idea that we can reference guidelines that may evolve over time versus something static that we're going to put into our rules, because I'm not sure what the future may hold with these guidelines. And I like the idea that getting coalitions of, because this is not just ASA, Dr. Zafran mentioned this is a variety of physician organizations that created these more updated guidelines. So that's kind of my take on it right now.
That's helpful. Thank you.
Dr. Naidu, again, my last question. The ketamine comes in different forms, like S-ketamine, compounding ketamines, some gummies, and different forms it's coming on. Are we specifically addressing compounding ketamine should not be included in this? Because we don't know what they compounded.
Sorry, I couldn't hear you very well, Dr. Naidu.
Okay, I'm sorry. The ketamine, the compounding ketamines, are they included in it? Because they can compound in any drug. We have the ketamine compounding drugs, S-ketamine, different forms of it, even IV.
Well, I think this is addressing anything that involves the administration of ketamine, whether it's part of another drug or not part of another drug. I mean, that's how I guess I would read it. But I mean, I'm not sure I'm getting what you're saying as far as, potentially having a drug that has ketamine in it that's not specifically called ketamine, or
Sharif, I think he's referring to S-ketamine, which is
Yes, and compounding ketamines too. Compounding drugs like GLP drugs, they compound it.
well, it should include any form of them.
Yeah, is there a pro-took?
My understanding is it includes any form of ketamine that is administered parenterally.
Okay.
Ms. Barnes?
Thank you. I think a practical approach might be that NPO would be a guidance and not necessarily a hard stop. I think maybe focus more on preparing the airway, making sure the staff is competent, and have a real-time risk assessment per patient. I don't know how you monitor that. It's probably improbable, but not impossible for someone, to have an event. But I don't know if you can say if we could use a proceed with caution type protocol rather than just canceling the whole thing. But I think you use ASA fasting guidelines as as kind of your foundation. And then in the clinic, if the provider wants to do an override, they can do that with very good documentation. But I think we should be looking at maybe more risk assessment and airway readiness per situation used.
Yeah, so Sharon, you're absolutely right, and that's what Zach was alluding to when he said that there is a judgment call that is alluded to in the guidelines. So even if I'm administering anxiolysis and I have somebody who's morbidly obese and has a bad, a difficult airway and is on GLP-1s, that to me is probably a fairly high risk patient that I would want to have NPO anyway, even though it's anxiolysis. And there may be others where you don't need to do that, but that's where the physician judgment and the assessment comes into play. And the guidelines does give that amount of deference. Now, if something bad were to happen, I mean, that's where the complaint process works. And, our judgment at that point was the standard of care followed? And the standard of care based on that physician's assessment and judgment, even though something bad happened, maybe fine. Again, kind of going back to that judgment call and what would a prudent person in the same specialty, in the same circumstance, what would they have done? So I think that deference is kind of given there. And that's why we kind of left that overarching guideline in there, because it does try to address as much of the different scenarios as possible. But at the end of the day, the most important part of it is that it does leave a certain amount to physician judgment, which is really what we're aiming for here.
Okay, thank you.
Dr. Tibbles?
Okay, sorry, I'm sure people are getting tired of hearing from me. By the way, I appreciate Dr. Jones, you and Dr. Zafran both as experts in this field, like putting in a public domain here your thoughts on that. And I think the way you articulated it makes sense. I don't know what to do with this. I just want to comment on it and acknowledge it. I think that so I'm happy that we're pulling back on the physician on site. I think that makes a lot of sense for access. I think we're putting in a lot of safety parameters that make me very comfortable doing that. I don't know that there can be an evidence-based approach to what is the right monitoring ratio, meaning like the idea that a physician's on site and we get 4-to-1. If they're off site, it's 1-to-1. I think we had a few people share comments to the whole board by email, and that was something I saw, and at least one of those was the concern that this 1-to-1 monitoring could be a little bit burdensome, both whether, again, I'm not making the point, I don't know whether it's the right ratio clinically or not, but from a staffing standpoint, it could be a significant burden. So I'd love to just hear the thinking around that. I don't know how we came up with it.
Jason, I'll weigh in on that. This is probably one part that I will absolutely not give in on, because for those of us who have actually looked at patients who are getting sedated, the whole point is to catch these people before they go down a downward spiral. Now, again, we're making a distinction between those who administer the drug, who can be an APRN or a PA, versus those who are monitoring the drug, which can be an RN, for example. And the whole point of this is that in that 40-minute time period, whether you're giving an IM dose or whether you're giving a sub-Q dose or an IV dose, if there's going to be a transition from anxiolysis to moderate sedation, unless you have one-to-one coverage, if you're like stuck looking at another patient and somebody's going down a downward spiral of not being responsive, and I actually saw this in a case that we were reviewing the other day, it didn't have to do with ketamine, but it did have to do with moderate sedation, where literally somebody who was supposed to have anxiolysis, and there was a physician present in the room and kind of, thought that the patient was responding, even though it was kind of moving. Patient wasn't responding. Patient was obstructed in a prone position and actually ended up having an anoxic injury and died. So this monitoring part, and again, this actually was something that was adamantly advised for by the psychiatrists who have been doing this probably more than anybody else. I just can't in good conscience sacrifice safety for convenience of access when it comes to that, especially when we're talking about RNs being used and being able to monitor,
So
not administer.
let's say I completely yield to that point of view to you as the expert, how do we reconcile the inconsistency between what you just said and softening those when the physician is on site? Why is monitoring 1-to-1 less important when the physician is on site than it is when they're off site, based on what you just said?
Because when the physician's actually there, you have three possible people that are there. You've got them and the APRN or PA, and you've got a nurse that's there, because you have to have somebody else who's monitoring as well as somebody who's administering. And what we had decided, at least from the standpoint of a physician judgment being there, is we can hold them accountable to a wider ratio if necessary. Now, myself as a physician, if I'm there, I would probably say I'm not really quite comfortable leaving it to that. But we're giving a little bit of deference to physicians when they're physically present there, being able to recognize these things probably sooner than if they're not there.
Okay, well, that's my last comment. Am I right that this is not my field of expertise, so I don't have a strong point of view. I'm asking, is this where we landed here based on consensus of the experts helping write the rule?
So the folks who were experts in helping write the initial rule were very much involved in helping write this rule, especially ASKP, and the psychiatrists were very much involved and engaged in helping with these modifications.
Okay. So as a non-specialist in this field, or if I were a public member, that would be important to me. So that's why I asked. So thank you for that.
Yeah, and just for a point of clarification on kind of how this process will play out too. Again, what the board is trying to decide to do today is if there is a new rule to put forward to the register for another 30-day public comment period, and then we'll take those comments and see if when we come back in June, if the board would like to make further changes to the rule or stick with what's been published. We did have a stakeholder meeting back in, I believe it was September or so, before we even brought this to the board in December. I think the idea is that we would have another type of meeting to go over this with the individuals that were part of the original stakeholder meeting, plus people that have submitted comments since that stakeholder meeting, both in writing or have given verbal testimony to the board. And so I think that's the idea, is we'd bring those groups of people back together to look at whatever is published today for potential changes in time for the June board meeting. And if it ends up that there's substantive changes, then obviously the board cannot adopt it. And in June with substantive changes, it would have to go back out for another comment period, and we'd be going on to August at that point in time.
And Brent, not that we would, but like using this as an example, some minor change in a monitoring ratio, like there's room for those kinds of adjustments that are not substantive that can be considered based on stakeholder comments and reaction to that. Is that accurate?
Yes, as long as it's non-substantive, right. And so usually if you're making something less restrictive, then that is something that is usually more permissible than, for example, if it was a 10-to-1 ratio now, and then you went to adopt it and you went to 1-to-1, well, then that probably could drastically change how people feel about the rule. But if you made it less restrictive, it's usually easier to go ahead and make those changes the day of.
And I would just add to what Brent said, is that the stakeholders that I would be interested in hearing from that feedback is actually those who are specifically the physicians diagnosing and monitoring these. And that's specifically been the psychiatrists. Other stakeholders who may be those who are, delegated to, or are being supervised. I think they can add a lot of color as to what is important from their standpoint. But when we really get to diagnosing and the treatment and the therapy and those specific guidelines, I for one feel like I want to lean heavily on those physicians who are prescribing and treating this directly.
Dr. Quinones?
Thanks. I just have a question, Brent, on section 173.9, operation of PKT clinics, subsection B, section B, subsection 2A course on the use of ketamine for psychiatric conditions. Are we going to determine what courses are appropriate, or are we going to require certified registered courses, or will the board have discretion as to what courses are approved for training, like we do for CME?
Yeah, Dr. Jeff, you want to talk about some of the courses? It will be something that is going to have to be approved by having the registration and the, part of the checks that the board would do. But as far as the course themselves, Dr. Zafran, you want to weigh in on those?
Yeah, thanks, Manny. We've actually looked and seen that there's several appropriate airway management courses out there specifically geared for, again, the level above anxiolysis, which is moderate sedation. So we have a list of courses that we can put out there. And obviously, if somebody has a course that they want to utilize, they can ask us for specific approval of that. I just again want to emphasize the point that I made earlier. Just being able to administer ACLS is not enough, because if you're having to resuscitate a patient by doing CPR, what have you, you've already you've missed the boat on monitoring and identifying early enough to be able to intervene and not have a sentinel outcome.
All right, other comments from the board? Again, the board can, if there's changes that the board would like to put forward as possible changes now, we can do so, and we can make some edits. The board can also continue to deliberate. The board can take comments from the public and see what suggestions come from that. If the board does make any changes now, that may change the comments from members of the public, that it may address a concern that they have. But again, it's kind of up to you guys on how you want to do it. Ms. Troncoso?
So real quick, two things. Number one, I just really appreciate what Dr. Tibbles is saying, and Dr. Zafran, I respect and Dr. Jones, I respect your opinion as anesthesiologists, but I do feel like because there's a psychiatrist in the room or a therapist that is actively talking to these patients that are getting the treatment, I think the idea of leaving them in a room and only having to monitor less frequently because the physician is in the building, I don't think it makes it that big a difference. And so I think that if you were leaving the patient alone and letting him just kind of deal with whatever he was doing and nobody was in the room watching him, I think that's one thing. But because part of it is them actively talking through these traumatic experiences, it's still therapy. They're still having a conversation with them. And so the person that's in the room administering the therapy is going to notice if the speech is slurred, if they stop responding. And so from that perspective, I still kind of feel pretty strongly about the fact that there maybe shouldn't be a difference whether the physician's in the building or not. And I'm comfortable with the idea that of the ratio of the delegates being the same, whether the physician's in the building or not. So that's one comment. And then my second question and comment is, I saw some of the email traffic that we got from these, public members or other physicians and things talking about mail order ketamine. And I wanted to make sure that I understand that this rule is going to prevent the access to that. And this will thereby make it a requirement that somebody's doing it in a supervised setting, and that kind of these Mind Bloom and other things that make it available for shipment of ketamine, even if they're one-time injectors, that this eliminates that. So that's a question that I have.
This does eliminate anything that is not parenteral. So it does not eliminate intranasal. It doesn't eliminate oral, but it does eliminate any kind of IV, IM, or sub-Q type of administration in a non-type of monitor setting. And, as far as your other remark, Linda, I mean, that's fine. We can always change that back to the same level of oversight. But I just want to make sure that I emphasize to all of you that what I've heard from the psychiatrists is that these patients are not being talked to the entire time that they're there. There are periods of time where they are left alone, and that is a message that I heard very loud and clear, that they are sometimes in a room by themselves. There may be a couple of rooms that these patients are in. Again, they might get that IM dose that is one single dose, but its effect is over 40 minutes. They may have a conversation with them 5 to 10 minutes later, but there may be another 20-30 minutes there's nobody in there with them. And again, that's what the psychiatrist told us. That was very clear to us, that they're not there. It's not that somebody's there. And if there was, then it's 1-to-1 anyway, already as it is.
Sure.
So that would kind of negate that whole point anyway. But the point is that my understanding is that there is not somebody there the entire time. And that's why we made a distinction between the person administering and the person monitoring the drug are two different people if the physician's not there. If the physician's there, the idea was that the person administering and monitoring while the physician's there could be the same, and since they wouldn't be distracted by having to see another patient. But again, it's open for debate, but it just felt that there was a lot more flexibility in how the drug was being administered and monitored when a physician's there, as opposed to when they're not there. Hence, the openness to some flexibility there.
And I appreciate that response, and that's a clarification. I didn't have the benefit of understanding what the psychiatrist had been saying. I was probably mistakenly assuming that whether it was a licensed counselor or somebody that maybe didn't have a medical background, but there's somebody in the room going, oh my gosh, this patient's not, his numbers are dropping, he's not responding, whatever it was. I was under the impression that there was somebody in the room at all times. So thank you for that.
No, that's why I wanted to hear very specifically from the psychiatrist, and I asked them directly because, again, to be honest with you, most anesthesiologists don't do this. This is not a business but obviously from the sedation component, it is our area of expertise. But I wanted to understand from those who are administering the drug or diagnosing and treating with the drug, what was the circumstance in which they were doing it with, and that was what was described to me.
Thank you.
Hey, Sharif, or Brent, what's the procedure for today? I'm assuming we're not taking public comment today, and what's on the table is for us to put this rule that as proposed out for public comment. Is that, can I make that motion?
Well, we do have people that are here that would like to speak, that have come today, that are both physically present and also have joined us virtually. So again, it's kind of up to the board on how they'd like to do it, but there are people that do have comments that they would like to, there's a limit to it. But we do have people that have made the.
I'm going to give a point of view. I want to be sensitive to people who have gone out of their way to come and make a comment. I think I'm biased towards trying to let them do that. At the same time, all of us are here in an ad hoc meeting with probably some limited time, and we got to get to a vote. So I don't know how the rest of the group wants to do it, but if it's going to be multiple hours of public comment,
Jason,
I won't be around to vote.
Jason, I think your point actually is well taken. We are set to have a focus group where stakeholders will be invited to come and have that conversation. So I may give some deference.
I'm going to make a motion, and then someone can say, we can ignore it. Well, I haven't made it yet, but and I'm going to give you some reasoning why I'm making this. I think the rule as proposed leaves lots of opportunity to debate publicly through public comment and on the other side of public comment, the things that even I had some concerns about, whether that's the ratio of monitoring or the inclusion of ASA moderate sedation guideline references. I think leaving those things in there, which are maybe a bit restricting, actually leaves the opportunity, to Brent's point, to pull those back without them being substantive changes. And there's plenty of opportunity to do that. I don't think there's anything that's going to materially change us going back and rewriting everything. So my motion is to put the proposed rule out as suggested for public comment.
Before you second, George, I would just like to make a motion for one small change. And you guys can accept that as part of the motion, Jason, and that can be seconded if you want to. But where it says, I would say, meets the latest moderate sedation guidelines published by the ASA, dependent on the intended level of anxiolysis or sedation to be achieved.
Okay, I really like that. And so I will absolutely accept that and add that to my motion.
Jason, this is Dr. Quinones, this is Manny. I'd also like to make a suggested change or edit with regards to the course for the use of ketamine for a psychiatric condition, that it be a course approved by our executive director or the board.
Are there any just sort of operational challenges with that? Anybody on the board, staff have feelings about that requirement?
What if we like?
I think it's something we can work internally if you want to have that. I mean,
okay,
it can be left. It can be left with the board, or it can be left for me to approve based on input.
Let me ask this: when we get to final rule, would language like that be substantive? And if not, I'm tempted to just kind of leave it out for now, Manny.
I don't believe that would be a substantive change.
Okay. So respectfully, Manny, I'm going to not accept that for my motion. You can make one, but only because, not that I don't like it. I just would like to leave time to like understand the implications of that. And it sounds like we can revisit it without it being substantive later. So
That's
I'm gonna say,
That's fine.
so I'm gonna,
I withdraw my suggestion.
okay, great. Well, I'm gonna add Sharice's language, and then that's my motion.
So we
Can I
do
get
need to,
clarity on can we repeat the motion and kind of the
Yeah.
action that's being proposed?
So
Or
Exactly, yes.
Yes, it says
I'm very
meets
confused.
meets the latest moderate sedation guidelines published by the ASA, dependent on the intended level of anxiolysis or sedation.
is that 173.10 subsection
Read
C?
C and D.
C and D? Is that where you're looking? We just want to get really specific.
Yes.
Thank you.
Yes, but I'm sure you guys will double check me, but
Correct.
yes.
Yeah, it's going to be in C and D, and it's back to the discussion that they had on the ASA guidelines were dependent on the intended level. So
Okay, we're offline right now on the board meeting, in the board meeting room. Why does it say
can't see.
offline? Hold on.
can you guys
So
hear
the
us?
Suggestion. Yeah,
Can
we
y'all hear
you.
us?
We
We
can
can hear you. We can't
All right,
see
all
you.
right. So just stand by. Our video went out, but we can continue talking about it
Yeah.
since we're not voting just yet. So yeah,
So
that-
Dr. Safran, we're adding, Jason, we're adding the edit to your motion that the rules as proposed with the edit from Sharif go to public comment. That's
right.
what your motion is?
Yes.
Okay, thank you. Okay, with the addition of what?
Yes. And if it's
Teresa.
seconded, I do suggest we take a minute and discuss before we just vote. Because someone may feel strongly that we should hear hear from the people that have come before we vote, and that's fine. But that's
Well,
my
what-
motion.
So one of the things for everybody, there is a public comment agenda item after
Yeah.
this board, this potential rule anyways. So we're going to hear all the public comment that exists. A quorum of the board is not required to have public comment. So I understand some of you may need to go, but staff is going to stay. We'll listen to every single comment that somebody has. We'll take notes of it. And we'll certainly present that to the board, make it available if anybody needs to leave. So if we get to that point and people do need to go, before we lose quorum, we will probably, maybe take a break from agenda item number 5, if that's what we're on at the time. We'll go to 6, and we'll have a conditional adjournment based on at the conclusion of public comment. So that's kind of how we'll wrap up administratively. But there is going to be public comment, so people can either make it on this rule on agenda item 4, or they can make it during agenda item 5.
But if they make it during 4, then we wouldn't have a vote yet.
Correct.
And
That's what I'm
so we
saying.
would need a quorum of the board to stay to hear public comment and then vote. If you elect to vote to publish this, then we don't need a quorum to continue with public comment, right?
Right.
Mr. Carlton, that's
Correct.
Okay.
Well, given that, then I second Dr. Tibbles with his motion with the edits from Sharif for this to go as proposed for public comment, and understand there's also public comment after we vote.
I have a question. Dr. Deloach here. Before we second that, it's just for my reading. When they say, when you mention public comment, do you really mention for publication in the Texas Register?
So there's 2 public comments. All right. So there's whatever rule the board adopts today, right? You can either hear the public comment from the people that have joined us that are either in the room or virtually. You can hear that public comment before adopting if you choose, or you can vote and then go ahead and vote to put it into the register. And then the public comment they want to give on 4, they would give in agenda item number 5. Now, in addition to that, whatever goes into the register, there will be at least a 30-day public comment period for us to continue receiving comments from people here today or anyone else that wasn't able to join us today before you take it back up in June. I hope that clarified it. So there's multiple public comments that's kind of getting thrown around. So you can either hear the people today before you vote on agenda item number 4, or you can wait and get their comments during agenda item number 5. And there will also be public comments during the 30-day window based on what you approve today.
Okay, that clarifies to me that if we vote now with the motion and the changes specified, then we can stay and after we vote up or down, then we can stay and get a prelude to the public comment as before as it goes to the Texas Texas Register.
Yes, those comments would be part of what we would
Okay.
review for the June board meeting.
And we don't need a quorum for that.
Right. The quorum is not required for the public comment period. But again, staff is going to stay and whoever else can stay to listen to everyone that wants to make one. Okay. Yeah. So yeah, we're trying to fix the issue here with our video. We do want that to be up and running whenever the vote is taken here. So staff will need just a second. I think they're going to reboot the system. So we'll be right back. Okay, I think we are back here. We can see ourselves in the video. I assume you guys can see us too now. So we do have a motion and a second to go ahead and publish the rules as presented with the change as suggested by Dr. Zafran in
173.10.
173.10 C and D, I believe it was. Yeah, okay. All right, is there any further discussion on that motion? All right, all in favor, please say aye.
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 Any opposed? Any abstaining? All right, so the rule will be put into the register. Staff will work on that and get it into the kind of guess the next edition as quickly as we can. And once it hits that edition, that's going to start the 30-day clock for accepting those comments. Obviously, we'll accept stuff before it officially gets there. We'll be accepting, comments that are being made today. And so that'll all be part of what is brought back to the board in June. And again, as a reminder, depending on any changes that come from that comment period or what the board does in June, it could make a change for either allowing it to have a final adoption in June, or potential any substantive changes could go back for another comment period and go to the August board meeting. So again, that will complete agenda item number 4. And let's see, do we have any of our board members that need to sign off now? We want to make sure we at least have 10 before we have to at least go to 6 and adjourn, have a motion to adjourn at the end of public comment. Or if you guys want, we can go ahead and do that now. We can skip over 5. We can go to agenda item number 6, and there can be a motion to adjourn the meeting at the conclusion of item 5, public comment.
Brent, just to give some deference to people who want to be able to testify, let's go ahead and officially, formally adjourn the meeting now, and then we can leave everything open for public comment as long as need be.
Okay, so the meeting will be finally adjourned at the conclusion of public comment.
It's conditionally
Right,
adjourned.
it's a conditional.
Yeah.
Yeah. All right, so then in order to do that, is there a motion for the meeting to adjourn at the conclusion of public comment?
So moved.
So
It's Dr.
moved.
Quinones.
Was there a second? I'm sorry.
Second,
Deloach, second.
Dr. Vanderwide. All right. So we have a motion and a second for the meeting to adjourn at the conclusion of agenda item number 5, public comment. All in favor, please say aye.
Aye.
Any opposed? Any abstaining? All right, motion carries, and we will continue on until we have heard everyone that would like to speak. So we'll go ahead and start with the individuals that are here in the room first. So whichever one of you would like to go first, please just go ahead and come up, push the button to turn the green light on. Just go ahead and state your name and who you're with, and you'll have 3 minutes.
My name is Kelly Light. I'm with Transcend. We're
It's good. Okay.
it's green. Can you
Yep.
hear me? Mhm. Should I move to another one? Okay. I have a soft voice. Okay, thank you. My name is Kelly. I'm a registered nurse with nearly 2 decades of experience in critical care and cardiac cath labs, and I'm currently at a PKT clinic called Transcend here in Austin. We also have a location in San Antonio, and we operate, Dr. Troncoso, kind of like what you assumed, where every infusion we have an RN and a licensed therapist in the session for the entirety of it. I want to address a fundamental issue driving this proposal. Ketamine-assisted psychotherapy is not anesthesia, and it's not conscious sedation, and it should not be regulated. We are using subdissociative doses well below anesthetic levels, administered slowly over about 40 minutes. At these doses, the evidence consistently shows no clinically significant respiratory compromise. Patients maintain airway reflexes, breathe spontaneously, and remain hemodynamically stable. Just as importantly, patients are actively engaged in therapy throughout the session. This is definitionally incompatible with sedation. This is not theoretical. At Transcend, we've performed over 4,000 sessions with one-to-one monitoring by highly experienced RNs without evidence of the risks being cited here. This proposal applies an anesthesia framework to a psychiatric therapy based on what-if scenarios rather than actual data. As a nurse, I have routinely administered medications with far greater risk profiles under physician supervision. Restricting RNs from administering low-dose ketamine in this setting is not aligned with standard medical practice and does not improve patient safety. What it will do is eliminate access. The financial impact is not abstract. The low end of market rates for a physician required to be on call and available within 30 minutes is approximately $1,000 per day. Requiring an NPPA to administer ketamine adds another $600 per day. In the month of March at our clinic, over 22 business days, we performed 73 infusions. To simply break even under these requirements, we would have needed to increase the cost of each session by about $480. Our sliding scale patients currently pay around $450 to $500 per session, and this would effectively double the cost of care. 75 to 80% of our patients rely on reduced fee access, and these are individuals with treatment-resistant depression and debilitating PTSD. They are not choosing between providers. They are choosing between receiving care and going without it. For some of them, losing access is not a neutral outcome. It is life-threatening. We are clinicians. Evidence-based, data-driven practice is the foundation of safe patient care. Implementing sweeping regulatory changes without evidence and in direct contradiction to existing data is the antithesis of that standard. I respectfully ask the board to allow existing ketamine clinics to register now and continue operating under current models so that we can collect empirical safety data over the next year and then make informed evidence-based decisions about whether additional regulations are warranted. Because right now, this proposal will not improve patient safety, but it will reduce access for the patients who are often out of options. Thank you.
Thank you. And so just to clarify for you, your recommendation as of right now is not necessarily adopt any rules, just have the existing ketamine clinics register and then collect data over the next year.
Exactly, because there are definitely some clinics out there that are not operating as ethically as ours, and there needs to be some regulations. But I think to this degree, we'll close all the ketamine clinics out there and we won't be able to get any of the data.
Okay, great. Thank you.
Thank you.
Appreciate it. Okay.
Good morning, everyone. We're still in the morning.
Still morning. Yeah.
I am a licensed professional counselor associate that also works at Transcend here in Austin. My name is Tim Geltz, and the main point that I'd like to make today is how this is an interwoven relationship between medical practice and mental health practice. As my colleague just stated, not all ketamine clinics operate the same way, and there are some things that I would like to discuss as a mental health professional in this space. My main concern about the newly proposed rules comes in the statute 173.6B that requires that a physician give a diagnosis to any person about to or possibly going to receive PKT, or as we call it at Transcend, KAP, ketamine-assisted psychotherapy. As a mental health professional licensed by the Texas Behavioral Health Executive Council, I am qualified to diagnose mental health conditions. So for clinics that do operate with mental health professionals in the clinic, I would like to see the ruling changed such that the medical director could defer to mental health professionals. Again, I really thank the board for their continued attention to this important matter and the concern for patient safety, because that is what we are all here for. On the medical side, I think there's appropriate concern for the risk of treatment. On the mental health side, our concern is the risk of not treating. This is approved for treatment-resistant conditions, and the occurrence of suicidality is extremely common in these populations. And this is something that we take extremely seriously. And for people who are going to receive PKT, or as I said, KAP, this is one of the main concerns that we have. We go through extensive monitoring and make sure that there's a safety plan in place for people who do experience suicidality. Then my last note on the mental health side is that for particular mental health conditions, I believe that it is necessary to have mental health screening in place, because there are particular conditions such as a personal or familial history of schizophrenia that it is not a good idea to engage in psychedelic therapy like this, as well as bipolar. Now, I am a licensed professional counselor. It is not within my scope of practice to discuss prescribing psychiatric medications, but it is easily mitigated, the risk of the risk of creating a manic episode in anyone who experiences bipolar if they are mood stabilized. Again, though, I would defer to my medical team as to what would be the appropriate medication for them. Thank you, everyone, for your continued attention on this.
Thank you. Appreciate it. Absolutely. You don't have to keep holding it. As long as the green light's on, you should be good. There you go.
Hear me now? Okay.
Yeah.
So in review of the literature, I only found 2 instances of harms from low-dose ketamine infusions. Both of them were in people's homes, and they were prescribed by telehealth companies. More importantly, I can't find a single case report of a patient requiring airway management at ketamine clinic. Not one that I've found. I don't know if there's one out there that I haven't found, but I tend to find that these are sensational when they happen, so we know about it. On a conservative estimate of how many ketamine infusions have occurred in the last decade, it's probably about 15 million. And so to compare, the rate of anaphylaxis from flu shots is about 76 cases and 12.7 million. My point is we don't require a physician on site or a physician to be able to respond within 30 minutes to a CVS. I can personally attest that I've monitored thousands of ketamine infusions, probably about 10,000 hours watching patients on ketamine. In the last 6 years, I've never seen a patient develop respiratory depression. I've never seen a electrospasm. And I've never seen a patient become unstable. Not one time. Patients speak freely during ketamine infusions. This is not moderate sedation, and these rules are based on as if it was. Patients are completely responsive in the subdissociative ranges, under 1 milligram per kilogram. These infusions are administered for 40 to 60 minutes. This is not an IV push. This is not moderate sedation. This is not anesthesia. APPs and nurses are more than capable of ensuring safety for ketamine infusions at these dose ranges. There's not even a signal of risk in the literature that we can find. A 30-minute response time for a physician does not solve for any situation that we actually see in the ketamine clinics. So I think that that should be stricken or discussed in depth. What we are actually seeing from watching this industry over the last 6 years is a rise of telehealth companies. This rule does not adequately address telehealth companies. It stops them from sending vials to patients' homes to self-inject. Thank you for doing that. It does not stop them from prescribing for daily use. It does not stop them from prescribing 1,200 milligrams doses to patients. Those are the doses that we've seen in the harms. So I would hope that the board talks a little bit more about the telehealth companies and a little bit less about airway risk in clinics that we have never seen. Thank you.
Thank you. I appreciate it.
Hi, I'm
Hello.
Annabelle Morris. I'm back. I am a therapist. I'm actually also a CPA. I wanted to have a chance. I was looking through Jennifer's Law and the kind of ruling that has been made for med spas. And I think in that case, typically the response was the ruling was brought up in response to a death in a med spa. If we look at kind of what ultimately got passed and all the way through kind of passed by law, which the governor, multiple people were saying were safe protocols, it allowed an RN to give an IV without a physician on site, and that the physician was just available for immediate consultation. And that was kind of something that was done in response to an actual death. So we haven't had a death at a ketamine clinic, but we're going to have more increased regulations and things that are required when there's also a life-saving measure in terms of suicidality, mental health. When at a med spa, there isn't that. But we did want to make sure there was still access to care for med spas. So I am kind of asking that we consider paralleling this ruling to kind of what has already been agreed as protective in Jennifer's Law of allowing RNs to do the administration and monitoring, allowing a doctor to be available for consultation, allowing there to be informed consent for all patients, understanding what the risks are. And I think that going in line with that same kind of thought process, it doesn't really make sense to me why we wouldn't, especially when it has been proven that there are deaths in that industry. But I think also there is going to be a significant impact to small businesses. I think I read that there was no impact to small businesses in the initial kind of proposal, but this is going to greatly impact small businesses. Even the small businesses that are able to stay open will have significant increased expenses, significant new protocols. And whenever there are new protocols, that actually leaves more room for risk, because now staff are having to get trained. Now there's more things that could go wrong as we change things. And I believe it is kind of ultimately not trusting the physician who is putting everything under their license, that they do have the competency to delegate these tasks to ensure that all their medical staff is competently trained. And I think, as we saw in Jennifer's law, there was an emphasis on making sure there was correct training and protocols, and that the physician had deemed that all people who were in these positions did have the adequate training. And I don't really see that same thing mirrored in this proposal around the ketamine clinics. And I am confused why it's a little bit different in this case when there has not been a death.
Thank you for your comment. I'm sorry, did I hear right? Are you all with Transcend? Yes. Okay. All right. I thought so. Again, I appreciate you guys, your comments. You kind of heard a little bit of everyone's had something different to say, which again, I appreciate that. You know, that it is helpful that if everyone's not necessarily saying the same thing over and over again, we can hear kind of different aspects of it. One of the things with the first commenter was like basically have no rule, but just kind of get everyone to register and then see kind of how it goes over the next year to gather data. But we have heard some other comments of like, hey, thanks for maybe prohibiting the at-home use without the monitoring and stuff. So is there some amount of the rule overall that you guys do support and there's just parts that you don't? Or is your idea from Transcend's point of view just to have no rule for a while requiring the registration and gather the data? Okay. All right. Just want to make sure it's kind of clear. What would be great for you guys, for us, and for everybody listening, for whoever else wants to give comments to us. The kind of comments you guys are giving are helpful, but would be even more helpful for us to look at is if you take whatever the version that they just passed and send us back like the track changes, the strike throughs and everything, like, hey, this part was okay. This is what our recommended language here. Strike this, add that. That would be really good because that way it'll be in your own words of what you guys are kind of looking for. All right, great. Thank you.
Thank you.
Yes. All right. All right. First hand to see up is for Amanda.
Yes, hi. So I'm also with Transcend Health Solutions. I'm a nurse practitioner. Can you guys hear me okay?
Yes, we can.
Okay. Well, I appreciate the board meeting again to re-examine this proposed rule and in general the attention to this issue, because at our clinic, we have a very high medical standard, especially relative to other clinics. Unfortunately, we've heard some bad stories. So I do appreciate that some regulation is coming down the line, although, I do have some issues with a couple of the things. So I have two questions and two comments. So one is in regards to the 30-minute physician response time. So having worked in the hospital, I spent probably about 20 years working in critical care as a paramedic and then a registered nurse and then a nurse practitioner. So in the hospital setting where there's physicians all over, if a patient begins to decline, especially if you're in the ICU where you may or may not have a physician right there, typically you would call the physician, and to ask what the recommendations were. And then if the patient further declined, you might do a rapid response where a rapid response team will come that may or may not include a physician or a mid-level. And then if they decline beyond that, to a code, then you will get a physician. But when you make that phone call, that physician may or may not be within 30 minutes. So the way this parallels to ketamine clinics is if you have a declining patient, you would call the physician. They would manage what could be managed in the scope of a telehealth or just like a phone call. And if a patient's declining beyond that point, EMS just needs to be activated. So especially if the nurse has determined that a physician needs to be physically present on site, by that point EMS should just be activated. So the 30-minute response time just seems like almost an arbitrary, unnecessarily burdensome requirement. And I do question how that rule came to fruition, if it was based on some precedent or, that number was maybe arbitrarily thrown out. I don't know. It's just something that I would encourage the board to maybe further examine. Another thing that I was wondering about was the negative urine pregnancy test. So the Society for Obstetric Anesthesia and Perinatology does not prohibit ketamine use in pregnancy. ACOG, SM, FM have not published guidelines on ketamine safety in pregnancy. So when these more specialized groups have not prohibited ketamine use in pregnancy, I'm just curious how the TMB has made this determination of a risk high enough to warrant a negative pregnancy test with every infusion, when these infusions can sometimes be 1 to 2 times per week. So I'm just curious what data supports that, especially when you consider that the average PCP or ER provider is not getting a urine pregnancy test before ordering Cipro or Bactrim, which are at least category C. In those cases, you just ask the last menstrual period, which seems like it should be sufficient for ketamine, which is actually safer than those standard antibiotics like Cipro and Bactrim. A question I have, and I don't know if this is the time where I would ask a question, but so the Texas Medical Board doesn't regulate registered nurses or nurse practitioners. Obviously, that's the Board of Nursing. But I'm curious, the rule, obviously it's outlining what additional training they want for physicians like airway management and whatnot. But is a nurse practitioner or PA, what is their involvement in the intake process? I know it says they can administer, but is the board proposing any delegation changes as far as mid-levels go and their involvement in the intake process? And then my last comment is just, as it's been mentioned already, having been with Transcend for 6 years, we have never had one adverse airway event. We've done thousands of infusions. And so I'm just wondering, again, what is the data driving some of these proposed rules? I know I'm sure physicians are familiar with availability bias, where there's a very statistically rare adverse medical event, and then sweeping changes are made to practice based on that very rare event, when those sweeping changes themselves might have negative implications, like in this case, affecting access to care for suicidal patients, which could potentially lead to more deaths than a very statistically unlikely event that we've never even seen in 6 years. So yeah, those are my 2 questions and my 2 comments.
All right.
So this is Dr. Zafran. Let me just answer the first question. So I'm going to read this directly out of the guidelines. Ketamine is typically not recommended during pregnancy due to a lack of human safety data and concerning animal studies. While it may be used in rare medical emergencies, both the FDA and medical experts generally advise avoiding its use for elective or psychiatric purposes while pregnant. That is directly from the FDA. So we don't typically just nilly-willy try to put some guidelines out there, but that is one that comes directly from them. As far as concerns about studies that are out there and so forth, again, speaking with those who do this, I believe with a fair amount of care, and I'm speaking now specifically to psychiatrists who, we've kind of leaned on in looking at this process. There is a lot of anecdotal evidence, obviously, that this works for folks with PTSD, suicidal ideation, and so forth. But we're kind of struggling a little bit with this idea that suicide rates are going to go up all of a sudden if we are more restrictive, seeing how I haven't seen any data on the other side where, where is that 30-40% decrease in suicides since this was started? It may be there, but what we do know is that this is an anesthetic drug, and I understand that people like to use the term sub-anesthetic dose, and what we're trying to reiterate is that folks who are on other psychotropic medications, antidepressants, whatever it might be, those drugs also have a sedative effect. Add on to that some of these patients might be chronic pain patients, also taking opioids, maybe on an intrathecal pump. whatever
Sorry,
that
we're not
might be.
able to hear you from the boardroom. We just lost power. So
Can you guys
please
still
stand
hear me or
by.
not?
Please stand by.
Yes, can hear you.
I can hear you.
I think it's only the boardroom who can't hear me, but the folks on Teams can hear.
There's still problem solving. Thanks so much for your patience.
Hello, sorry, we're back again. It's now twice our system has failed. We can set up a GoFundMe maybe so that we can get a new server. So I'm sorry about that. I think Amanda, you were finishing up your last. Is it Amanda? I'm sorry. Or, anyway, yeah, I'm sorry. And Dr. Zafran was responding. Yep.
Yeah, no, I'm not sure where you guys stopped hearing me, but I did talk about what the FDA said as far as ketamine and pregnancy is concerned. Yeah,
right.
That's very clear and it's there. And as far as, again, going back to physician oversight, again, we are very specifically regulating physicians. We're not regulating anybody else, but we can regulate physicians and their responsibility in supervising and delegating, and their need to be responsive in a timely fashion. This is not like a typical med spa where somebody could be in Colorado supervising and overseeing something that's going on in Texas, especially with a drug like this. So from our standpoint, our viewpoint is that the physician who we regulate needs to be within 30 minutes and to be able to respond in a timely fashion that way. And as far as like nothing bad happening, there are lawsuits that are out there. that are going through the process, and there clearly is incidents where bad things can happen, and it's not almost 0%. It's more than that. There's a lawsuit out there that talks about a lady that took ketamine at home, and I believe it was parenterally, and reached a dissociative state, ultimately killed all her 3 children, and also attempted to commit suicide herself in that dissociative state. So this is not an academic type of exercise. This is a dangerous drug that has some great uses if used appropriately. And our job in regulating our physicians in utilizing this drug is to make sure that it's done in a safe manner.
Okay, we've got next is Jack.
Good afternoon now, board members. I really appreciate you all having your careful deliberation of this issue. I'm here on behalf of the Texas Nurses Association. We will have more substantive written comments to provide, but more so what I wanted to say today was I assume this is happening, but you know what they say about assuming. So given that there are some implications for APRNs and nurses, I would just encourage board staff to talk with the Board of Nursing and just make sure that this is something that you're collaborating with them on, because there is potential overlap or conflict in some of the regulation of both practices. So we'll have more substantive comments for you all, but I just want to thank you. You know, patient safety is obviously a shared goal, and I appreciate the efforts y'all are making.
Great, thank you. Appreciate it.
Yeah, I was going to say thank you very much for that. And Brent has been communicating with the Board of Nursing, and there has been some good suggested language just to make sure that it's clear, where the oversight is. So, and that will also continue on. So appreciate that feedback.
Wonderful. Thank you, Dr. Zafran.
Yeah, for example, we didn't get to it today. It's a non-substantive change, at least as far as the board is concerned. But one of the things that was raised, sir, was around kind of the wording in 173.9D, as just as an example. Again, the job of the board is to regulate physicians, not nurses. And what we're trying to get at in that one was requirements for the physician. So we do have some potential language that we can make that clear that this is a requirement on the physicians and not on nurses or other regulated licensed populations.
Appreciate that.
Okay, next is it Michelle?
Hi, yes, thank you. You're able to hear me okay?
Yes, we can.
Yes, ma'am.
Okay, wonderful. I just want to thank you all for the opportunity to speak. My name is Michelle DeLeon, and I'm a nurse practitioner and clinical director for Illuma Ketamine Clinic, where we have conducted over 15,000 ketamine infusions since we opened in 2019 and have not experienced a single airway emergency requiring intervention or stabilization. Like Transcend, we also do not leave patients alone in rooms after dosing them with ketamine, and allowing clinics to do so seems negligent, so I would love to see the board consider this for the proposed rules. I was present in the last meeting, and I think it's important to address a few things that were brought up that kind of muddy the waters of what is being proposed in these rules. The proposed board rule requiring physician-patient relationship to be established limits the scope of practice for PAs and APRNs who are also able to diagnose and treat. The board rules propose that clinicians be required to receive ketamine provider training. And as Dr. Quinones mentioned, setting a standard for what this training looks like would be really important, because assuming that all providers take a similar ketamine provider course, how then does their ability to diagnose, treat, and care for clients in PKT clinics differ vastly? PKT is a treatment option in the toolbox of all practitioners diagnosing these conditions. Next, there were several comments made emphasizing the necessity for a clinician to be able to manage an airway emergency with the skill of intubation, which is not proposed in these rules, but rather that clinicians be trained in airway management or moderate sedation. The ASA offers a course on moderate sedation for non-anesthesiologist providers, i.e. psychiatrists, APRNs, and PAs. This course teaches the core rescue skills needed for rare complications seen with ketamine, which largely preserves spontaneous breathing. The ASA treats all non-anesthesiologist providers uniformly once they demonstrate these competencies. provider degree does not confer additional basic rescue capability in this setting. Competency is determined by the shared training, not the title or the provider types. Wouldn't putting a cap on the max dosage allowed in PKT clinics, for example, a maximum of 1 milligram per kilogram over a 45 to 60-minute infusion, significantly lower the risk of any airway emergencies or other adverse events? Additionally, several wrongful death cases were mentioned, most of which were with the use of at-home oral ketamine, and none of which were with the use of clinically supervised parenteral ketamine. I also was unable to find any evidence of such events in the PKT setting, and I'm curious if the board has found any such cases they can reference. This is all to say that this is clearly a very nuanced topic. Not placing restrictions on unsupervised at-home oral use likely will increase the risk for airway emergencies that could result in more deaths, as well as increase the abuse potential as we have seen in the opioid crisis. Allowing oral ketamine to continue to be available is contradictory to both of these stated concerns from the last meeting. Limiting the scope of practice for APRNs and PAs by requiring a physician to establish a physician-patient relationship will significantly limit access to care. Limiting APRNs or PAs to manage half as many clients would also, than would a physician who were on site, will also limit access to care. Ultimately, limiting access to care in the PKT setting by implementing these rules will likely result in some clients seeking out far more dangerous options for their treatment. Thank you for your time.
Ma'am, thank you.
Michelle, if I could
yeah,
ask
go
a
ahead.
quick question to you. I'd like to ask a quick question.
course. Yeah, go ahead.
If we took PKT out and I said propofol, would your views and thoughts on us regulating what we're doing change?
That's a good question.
I personally, I mean, again, that use would be for true sedation is my understanding, and that's not what we're doing here.
No, there's been talk about propofol being used also in depression, refractory depression, helping with sleep and quote unquote sub-anesthetic doses. Both propofol and ketamine are anesthetic drugs. There are potentially some dose of it that may be considered not to the level of anesthesia, if someone to call it sub-anesthetic. Before Michael Jackson died, there was some talk about propofol being used to help people sleep, even though it doesn't help with stage 4. So again, if we were to replace PKT with propofol, would your view on, the way we have our rules in place, the way we're talking about certain monitoring, all so forth and so on, would that change at all if it was a different drug like propofol?
I'm not disagreeing with the monitoring requirements as far as the actual vital signs that are being suggested. I think that's very appropriate. And again, that's hypothetical because propofol is not currently being used for those indications, so I cannot speak to that.
Okay. Is propofol typically something that can be diagnosed or treated without without a physician being involved?
Is propofol something that can be diagnosed or treated without a...
So is there a diagnosis or a treatment, a therapeutic treatment that a non-physician could do with propofol, which is an anesthetic agent?
Not to my knowledge, but I don't truly know the answer to that question.
Okay, so ketamine is an anesthetic drug also. It may be in doses that can be given that are low, but it's a non-reversible agent. So I'm just trying to understand what is the difference between ketamine and propofol, except the fact that in low doses, it does maintain spontaneous ventilation, but in patients who are on other antipsychotropic drugs or maybe on other pain medications and so forth, that additive effect certainly can have an impact also.
Surely, which is why it is important to not leave clients alone in rooms unattended. And it's important to require the training that you're proposing these rules. And I'm on board for all of those things.
Oh, good, thanks. That's helpful.
Thank you.
Ma'am, before you go, you said you're with Illuma, is that right?
Yes, sir. Yes,
okay,
sir.
great. And you said you had a recommended dosage limit?
I mean, I'm just suggesting if we're really, this is in the name of patient safety, and we're trying to stay out of that moderate sedation plane as much as possible to reduce airway emergencies and other adverse events, it's reasonable to consider a maximum dosage of 1 milligram per kilogram over a 45 to 60 minute infusion. And these rules don't make any suggestions in regards to that. I know that that's also kind of transcends, dosing max or close to that. So I think that would be something to be considered.
No, I appreciate it. I just want to make, I didn't catch it when I knew you had said it, but I didn't catch the exact amounts. So I want to make sure I got that in my notes.
So Brent, just a
Yeah.
second follow-up question just from a nuance standpoint. So would you have any concerns if that kind of dosing was given IM as one dose initially?
I mean, potentially, again, I think that's patient specific because of the risks of IM and the fact that we don't have the leeway to stop the infusion if we do start to see that there's any sort of adverse event occurring. Then yeah, I would have some apprehension on that. And, that could be something that be further teased out as, as patients' risk factors increase, they're morbidly obese, they're on other medications that would increase their sedation risk, that maybe they're not candidates for IM and only candidates for IV.
So somebody who may be on an intrathecal pump, getting maybe like what's equivalent to about 80 milligrams of morphine a day because they're in chronic pain, but they're coming in for PTSD, would half a milligram per kilo be more appropriate for them, or would a milligram per kilo still be appropriate, or how would you tackle that part?
So our starting dose for most clients is 0.5 milligram per kilogram. And so obviously when you start there, you're able to kind of assess the client's response. I've never in my time doing this seen a patient come in with an intrathecal pump. So again, I think that's not a very common patient presentation. But yeah, I mean, that's all the more reason to be very conservative in dosing when there are those added risk factors.
Okay, thank you.
And it would be helpful, ma'am. I mean, you may have heard me say it earlier, but I just want to make sure, like with Transcend, and again, great comments from them and from you. If you could give us kind of a strike through of like whatever recommendations you would have from Illuma of what you might like the rule to look like, that'd be helpful for us.
I'm happy to do that. Yes.
Great. Thank you so much.
Thank you.
All right. Next up is Dan.
Hi, good afternoon. I just wanted to take this opportunity to thank the board for being transparent and allowing us to see the discussion going on. The reason why I attended today is because I'm a retired U.S. Army Lieutenant Colonel who is also 100% disabled. And my concerns with regard to these changes are the potential closure of clinics in the Killeen Belton area. That the clinic has fewer than 5 or 10 people. The cost analysis alone, or that the additional costs alone are going to shut them down. And it's my belief that we're already seeing that happen. But I want to be clear that the rules that state simply, they don't meet the requirements set forth in Texas Government Code 2006.002 C1 C subparagraph C subparagraph C1. Is Mr. Fretchwell here?
I'm sorry. Is who here?
Mr. Fresher?
Oh no, Mr. Freshour is not here today. I'm sorry.
Okay. Well, because this is, I mean, from a legal standpoint, the rules as published, they simply don't meet the legal standard. According to Texas Government Code, the changes require both an economic impact statement and a regulatory flexibility analysis. The statute, which triggered by the mere possibility may have of adverse effect, and the agency must take affirmative actions to reduce that effect where feasible. And that's 2006.002 subparagraph A, subparagraph B. Specifically, a conclusory no effect statement in the preamble does not satisfy the statute when the rule's plain text demonstrates otherwise. And this was done in the preamble as a no cost impact. Now, as I said, the statute's triggered by the mere possibility. The leading legal argument is Unified Loans Incorporated versus Pettyjohn, 1997, where the Austin Court of Appeals squarely addressed this instance within the context of a Consumer Credit Commissioner rule that imposed knee compliance organizations on small loans and companies. That agency only had a conclusory statement in the preamble, just as we've done here, that it would have no effect. The court held that section 2006.002 is expressly and unambiguously triggered whenever a rule would have adverse economic effect on small business. Specifically, let me talk about some of the requirements that are actually triggering these costs. Obviously, we've already discussed the one with the doctor. I think that one's been done ad nauseum. But when you also start talking about sedation training and sedation rules and new equipment, those are clear, unambiguous costs. For example, let's see, I've got one here. Sedation training, such as is required, is only done in both Dallas and Austin, and could cost up to $10,000 to $15,000 per person to attend. A small clinic run by an APRN simply not going to be able to afford that. There was a little bit of talk earlier about oxygen, requiring oxygen on station. That alone is $3,000. When you've got small clinics that are barely breaking even, where there's are undertaking their endeavor because their passion for veterans such as me, it simply, these rules become unfeasible. And once again, you guys are required to publish both of those analyses, and they're required to be published in the Texas Register along with the potential rule changes. I would like to go back to what Nurse Kelly White recommended, where
Sir,
you would
sorry.
Yep.
If I can get you to kind of wrap up, we're past your 3 minutes, and there are some others that want to speak as well. If I could make sure, and again, thank you for your service. I appreciate that and your service in the Army. If I can kind of summarize your concerns. Your concern is on the economic impact implications of the rule, and then the potential costs for equipment, having a physician on site, the amount of staff for monitoring, it's things of that nature, and the training requirements.
That's correct. And Nurse Kelly White already provided the perfect recommendation. Suspend rule change for a year, but require reporting, and that will allow you to gather all of the data required in order to implement these types of rules. Thank you so much again for letting us speak.
Yes, sir. Thank you. Okay, next. Is it Tamara? Oh, I'm sorry. Sorry, I'm really wrong. Sorry, Tamara. I jumped you too quickly. It's Christina Potts. There we go.
There you go. Thank you. My name's Christina Potts. I'm the mother.
Sorry. Your audio is coming across as very distorted. It's like it's like really, really slow. Yeah. Is it coming across back for us too? Oh, it's going in your speaker back.
We tried. Does that work?
All right, Christina, could you, just mute your microphone for a second? Okay. All right. It is. Joe, she's still here. She's still with us. Yeah, if you could hear the kind of the feedback, Christina, that's how it was sounding for us. But we want to hear what you have to say, though. Okay, so I'm going to move on to Tamara. See if you can check something on your with your microphone, or if you need to leave the meeting and reconnect. But we'll definitely hear from you. Okay. That's what I mean. You may want to leave the meeting and try to get back in. We'll see if the audio is better for you. All right, Tamara, we'll go with you.
Good afternoon, members of the board. Thanks again for the opportunity to speak. I want to say thank you for your continued willingness to find the best solutions for this issue at hand. I'm speaking a little bit off the cuff because I'm actively, well, not actively, I'm in a break right now, but treating patients in my ketamine clinic. So I wasn't expecting to be able to pop on. My name is Tamara Vaught. I am both a CRNA and a psychiatric nurse practitioner, and I'm the owner of Ketamine Clinic of West Texas here in Midland. I'm the only clinic in West Texas servicing approximately a 200-mile radius around me. There's no other active ketamine clinic, largely because many of the clinics already closed in fear of the earlier proposed rules. So I have patients coming to me from the Panhandle that were treated in Lubbock and Amarillo, who now come down to me in Midland because their clinics closed in anticipation of the rule that was proposed 2 weeks ago. Two things I wanted to address was the very real impact that these rules are having on my patients. I began preparing my patients last week for the possibility that IV ketamine was no longer going to be available in my clinic. Many expressed significant distress and fear and uncertainty. There are individuals that rely on this treatment to maintain stability, manage their suicidal thoughts, and continue functioning in their daily lives. So I was preparing them after the board meeting 2 weeks ago, which I spoke at, and they're already beginning to feel the weight of that decision, as they would not be able to seek another clinic anywhere near in the area. They can't just go down the street to a physician-owned clinic or physician-present clinic. I do understand that these new rules that are being proposed take out the necessity for a physician to be on site. However, per the current rules for the APRN supervising physician relationship, there is not a current distance mandate for how close a supervising physician has to be to the APRN they're supervising. So my physician that has been supervising me for the last 8.5 years does not live in my community. So he would not be able to be here at my facility within 30 minutes. Obviously, we have very specific protocols in place that he and I designed together for an emergency situation, which would have our local Midland Police Department and EMS here within 10 minutes if I was to have an emergency. But over the last 8.5 years, I have never even had to pull the oxygen tanks out of the closet, nor any of my rescue equipment, nor call EMS. And I've treated hundreds of patients doing thousands of infusions. I wanted to address Dr. Zafran's question to the other nurse practitioner about propofol versus ketamine. As a CRNA of 18 years, obviously I have a very stark knowledge of both of those medications, using them in my anesthesia practice daily when I'm not in my clinic. And propofol is a respiratory depressant, and ketamine is known, especially in the doses we're giving in clinics, to be an airway, to maintain airway function, maintain both breathing and, in fact, it can be used successfully for patients that have respiratory disease. It can help with bronchodilation and help maintain airway. So to the question he posed to her, would my feelings be different if it was a rule about propofol? I agree with her that we're talking about two different drugs, two different scenarios. Propofol is not being used in this setting for this. While I have read some research that it is being proposed that it could be useful, it is not currently being used. And so would I have a different opinion if this was a propofol rule versus a ketamine rule? Maybe so, likely so, because I do know that there's a very fine line where giving propofol can cross someone over to an apneic state. It happens every day in the operating room. It's a very fine line. But my experience with ketamine, and especially administering in low dose over an hour administration for an infusion, that has never been a concern. My patients talk to me, they ask me for support, they ask for a blanket, they say they need to get up to the restroom, they comment about being nauseous or anxious, and I'm able to help and support them in all of those means. I've never had a concern about a patient losing their airway in my clinic. Again, I really appreciate the board's willingness to continue visiting this, continue teasing this out. I am concerned about patient safety, especially those that are using high dose ketamine in their homes. That's a really scary situation for me. But I do have fear that if my clinic has to close due to these rules, some of my patients will seek out online modalities to get the medication that has been life-saving for them. Thank you.
Thank you, ma'am. Again, appreciate your comments. As with the others, it'd be very helpful if you could take the proposed rules that are going to be published today and send back your suggested edits on those.
Yes, sir, I can do that.
Great, thank you. All right, Christina, let's see. Hopefully we've got your audio fixed. We can hear you.
I switched devices, so hopefully this is better.
Much better. We can hear you now.
Awesome.
Yes.
All right. Well, thank you. My name is Christina Potts. I'm the mother of an amazing 20-year-old whose life depends on access to ketamine therapy. My daughter suffers from severe hemiplegic migraines and other complex rheumatological and neurological diseases. Before low-dose PKT, she was completely bedbound, often unable to speak and participate in daily life. She has failed every FDA-approved hemiplegic migraine treatment option. Because of low-dose PKT, she went from completely disabled and in pain to attending Texas A&M full-time with a 4.0 in science, interning for Texas A&M, and pursuing a future in scientific research. That is real measurable improvement. Low-dose PKT, prescribed and supported by our multiple board-certified specialists, is the only treatment that has worked. She's receiving infusions for pain and other medical indications, not mental health, and she cannot get treatment after this month. She is now facing brain surgery on June 1st for a brain tumor. Her UT Southwestern medical team's plan included ketamine infusions before and after surgery to manage pain and prevent neurological decline. Some infusions have to be given outpatient. They have already been canceled due to these rules. These rules in practice eliminate low-dose PKT access for her. Without access, her choices are repeating already failed treatments or unmanaged severe pain and paralysis. This rule doesn't just regulate care, it's removing it for patients who are stable. This rule will cause patient harm. It'll cause harm to my daughter. Listening to the meeting, the board doesn't seem to realize that these rules are actually already cutting off care access. I'm already seeing it firsthand. She's already had appointments canceled. I've called so many places in so many cities, and I'm getting the same thing. I respectfully urge the board to nullify or at a minimum completely pause implementation of the rules for further study until medically necessary access for medically complex patients can be preserved. Thank you.
Thank you, ma'am. Okay. Any other comments for the board today?
As far as Sherry's not.
Okay, I'm not seeing any other. Oh, there we go. Yeah. Amanda, you have a follow-up comment?
I just had a question. I had brought it up before, but it was kind of just unclear in the response. So I know we discussed, that the TMB doesn't regulate nurses and nurse practitioners, but obviously you guys regulate physicians and what they can delegate. In the most recent rule change, it does mention physician training requirements, and it outlines what's expected with the with the physician involvement in ketamine. However, are there any changes in the delegate at this point? My supervising physician, we have like a delegation agreement in place that I can order ketamine. Is that change? Is that changing? That wasn't mentioned in the rule, but is that implied? Can you just expand on that?
See, Dr. Zafran, do you want to weigh in on that one? he may not be available to talk. So you're saying right now your physician is allowing you to prescribe and administer?
Correct. I mean, I no longer like when I was working as a nurse, I was administering infusions, but now I just do medical intakes. So yeah, I'm able to order, not prescribe. We don't prescribe for the home setting. We don't. Speaking for Transcend, we see a lot of issues with the telehealth home prescribers that many have already mentioned. So we only do in-clinic ketamine. But yeah, so every clinic that's spoken so far, all the nurse practitioners, it's the same thing. They have supervising physician, medical directors that through agreements with them, they're able to order ketamine infusions. So I did not see anything explicitly defined in the most recent rule change, barring that. But I do just want to clarify that in case, because it's not obvious.
So I think what we had talked about is for the physician having to be involved in the initial establishment of a physician-patient relationship, which can be done by telehealth or in person, and to make the diagnosis and the treatment plan. As far as the nuances as to what happens as far as ordering the medication to be given and so forth in the clinic, those obviously are just, will be based on what the law allows. But what we had very specifically talked about was that the initial establishment of the diagnosis and the treatment plan and so forth needed to be done by a qualified physician.
Okay, thank you for clarifying. But so at this time, it does allow the current ruling, as far as I understand, that physicians can delegate that me as a nurse practitioner, I can do that initial intake and order it. Of course, my physician's inherently involved in the whole process, but maybe not directly with each and every patient. So is this rule changing the existing delegation in place?
I do believe that the way it is written is that the physician needs to be the one directly doing the initial evaluation of the patient. And Brent, you can look at that, just correct me if I'm wrong.
Yeah, I think that's what's contemplated. I mean, again, nothing's changed as of right now, right? I mean, this is just proposed rule for going out for comments. So as of today, there's nothing different, and things continue operating as is until there is a final rule that goes into effect. But to answer your question, yeah, I think it is contemplated that there is that physician involvement for the initial part of the physician-patient relationship and diagnosis and the treatment plan. But again, as said before from Transcend and and the other commenters, if there's suggestions that you have on what you would like that to look like, then please make whatever edits you want in the rule and send that back to us for consideration to make things clearer, or to even kind of try to incorporate and talk about the way you guys are currently doing things, and that you're having safe outcomes with them, and that's the suggestion of what the rule should mirror. All right, next is Jeff. Oh, you're still on mute, Jeff. Still muted.
How about that?
There you go. All right.
Okay. I'm a lawyer in Austin. I was going to ask, to whom should we send written comments?
Give them go ahead and give them the, yeah.
So this will be published in the register. Once we file with the register the notice for public comment, the specific, designation and email address will be provided. We do believe it'll be included in that will be rules development. So sorry, my eyes. rules.development@tmb.texas.gov. But again, please check the publication in the register to obtain all details related to how to submit your written comment. Thanks so much.
Thank you. That's all I had.
Okay, thank you. Okay, let's see. Next. Is it Lakshmi? I apologize if I mispronounced your name.
Yeah, Lakshmi, thank you so much.
Yes.
And I'm Lakshmi Kolagunta from Houston, Texas, and from MD Anderson, and I'm representing Texas Pain Society. I'm the current president, and I would like to thank the board and Dr. Zafran for the diligence in making all these changes based on recommendations. As an anesthesiologist, and based on all the comments that I've heard so far, I mean, we know that ketamine is a scheduled medication and can be dangerous. And two things that I wanted to sort of ask the board and at least bring forth is what would we call a low dose, because it is so variable based on comorbidities, the patient medical condition at that time, and is there a defined low dose that can be put on this? The other thing is, we know that a dose can be okay for one patient but may not be okay for another patient, and when the patient actually slips into from anxiolysis to being sort of unresponsive is hard to understand sometimes. And being an anesthesiologist, that's why the ASA has put on these guidelines for moderate sedation, and totally agree that we need maybe stringent guidelines or guardrails as how do we protect our patients receiving this therapy. Those are the two comments that I had.
Great, thank you.
Thank you, Dr. Lakshmi. So just to answer the first question is, we did not on purpose put a low dose or a high dose, because as you said, it is dependent on the patient's conditions, their comorbidity, and what other medications that they're on. I can't find anywhere in any definition what a subanesthetic dose is, as all of us know that it is really dose dependent. And the example that I gave about somebody with an intrathecal pump, those are not, trivial examples. These are actually examples of things that I know have happened in similar situations or similar scenarios. So these are not anecdotal, just theoretical type of examples. These have happened before. But it comes back to the point, Dr. Lakshmi, why there needs to be an assessment by a physician at the very beginning to determine, number one, the proper diagnosis, and number two, the proper treatment plan. It does involve a PDMP check to make sure that that the physician's aware of the other medications that the patient's on and any kind of concomitant type of interactions it may have. Again, a chronic pain patient, as you know, could be on multiple opioids as well as multiple benzodiazepines, and they may be stable under that condition, but you give them a quote unquote low dose ketamine, whatever that means, and it may push them over the edge. And so that treatment plan, it's something that we do want our physicians to be the ones prescribing what that looks like and what level of oversight is needed, whether they can be 30 minutes away to help with issues that may come up, or whether they need to be in place at the facility directly monitoring what's going on with the patient.
Thank you, Dr. Zafran. To the same token, ASTRA has put forth guidelines for the low dose ketamine for chronic pain. So, I mean, is there a way, at least there can be a cap on what's the max dose?
So you're asking the right questions. Again, we went back to moderate sedation guidelines. We're worried about putting specific dosings there. I know 1 milligram per kilo has been suggested, but again, this is where we're going to be holding physicians accountable. But again, if you have a suggestion as to what you think is potentially appropriate, we're happy to take those under consideration. And let me just also emphasize that the use of ketamine for chronic pain does fall under our chronic pain guidelines and rules. So it would fall under different parameters. But again, to your point, it is something that we discussed. What is a low dose? What is a high dose? All that kind of stuff. Again, open to suggestions, but we didn't put anything specific in there.
We will put it in written comments when it's time for submission. Thank you.
Thank you. Is it Momin?
Yes, sir. All right.
Yep, go ahead.
All right. My name is Momin Zafarullah. I'm with NeuroGlow Clinic in Dallas. I do appreciate the board's dedication to patient safety and thoughtful work behind this proposal. We share that commitment fully. I'm also sure the board is aware that Texas ranks 49th in the nation for mental health access currently, and about nearly 5,000 Texans died by suicide in 2024 alone, which is why I'm specifically concerned about the diagnostic language in this proposal. Texas already authorizes psych NPs and LPCs to diagnose the very conditions this rule targets. Requiring a physician to re-diagnose or to diagnose on the front end what these highly trained clinicians have already established adds costs, delays cares, and conflicts with existing Texas law without adding any major benefit, in my opinion. I'm not asking the board to lower the bar on safety. I'm simply asking that the diagnostic standards in this rule reflect the qualified providers in Texas that Texas already trusted to do this work with. And my second point is our clinics have done roughly around 3,000 infusions over the course of several years. We've never had a medical emergency and or patients slip into moderate sedation where they're unresponsive. I do want to just share that opinion about that.
Thank you. It's like it's a similar suggestion that we got earlier in the public comment period about allowing the medical director or someone else to accept the diagnosis as determined by a non-physician professional. So I appreciate that. Okay. Is there anyone else that has a comment for the board?
Brent, are we making a distinction between diagnosing the person initially versus diagnosing and prescribing PKT specifically as a treatment? Because I think that's one of the questions that we had.
Sorry, I'll get my computer to come back on. It's gone to sleep while taking the notes here. Let me find where that was in here.
And when diagnosing and prescribing a treatment, establishing exactly what that treatment plan looks like, including dosing and so forth. I think that's where we're trying to be a little bit more specific about the guardrails with the comorbidities and other, multi-medications and so forth, as to being the ones who initially prescribe what that looks like and under what kind of monitoring conditions.
So the way that it's written in here right now is it's saying, for the physician requirements, saying the physician ordering PKT must have properly established physician-patient relationship and have properly documented and diagnosed the psychiatric indications supporting PKT.
Which is what I was saying. Exactly.
Right.
Yep. I just want to make sure that distinction is there, that we're talking specifically about diagnosing it in the context of using PKT as a treatment.
Yes. It has to have the diagnosed psychiatric indication, yes, for the use of it. So again, open to suggestions. I believe you said you were from, the last commenter was from NeuroGlow Clinic, if I got that correct. Open to suggestions you guys have on what wording you think would be better as far as striking that balance of patient safety and access to care. Okay, I'm not seeing any other hands up at this time. So by the motion that you guys had in agenda item number 6 earlier, that will conclude this meeting at 12:45 p.m. Thank you, everyone, for board members for your participation and for everyone that has been on and shared their comments today.